Back. I'm hoping you can hear me. It's been a while since I've done one of these. I posted on Facebook only recently asking people to let me know what they wanted me to teach them. And one of the topics that came up was how do we prepare for intubation? So that's what I'm going to teach you briefly today. I hope you find it useful. There's going to be more of these. But for the meantime, let's start with probably one of the most important things that we need, and this is going to base our discussion, and that is going to be the checklist. So if I just swap my screen there, you can see the checklist that I'm going to use. So first and foremost, the checklist is really important. They sometimes get used, they sometimes don't. I often find that they don't tend to get used when it's all a bit of a panic and a flap. And quite frankly, that's the time when they should get used, because that's the time when things will get missed. So if you can persuade whoever's leading it to use the checklist, then please do. It just helps ensure that things don't get missed, which can make the whole thing a bit of a disaster sometimes. So let's work our way through the checklist. This is from the Difficult Airway Society and the Intensive Care Society. If you go to their websites, you can find it there, or if you just type in intubation checklist into Google, this is what you will come up with. So what do we need? What does the patient need first and foremost? So we're going to prepare the patient, then we're going to prepare the equipment, then the team, and then for any possible difficulties. So first and foremost, we need some IV access, and preferably we need two sources of IV access. The reason we want two is because if one fails, then we've got the means to use something else. There's nothing worse than giving them some sedation, giving them some paralysis, and then suddenly your IV stops working and you've got a sedated and paralyzed patient who might need other drugs to maintain their blood pressure, for example, and there's nothing you can do about it. And you can be sure that some of the drugs that we give for intubation will drop the patient's blood pressure. So it can be quite essential that you have that intravenous access. You need to optimize their position, and this is something that people who are used to airways get quite fussy about as well, and quite rightly. They want really what is traditionally called the sniffing the morning air position. So you want your patient as if you're reaching out and sniffing the morning air. So they'll often ask for a pillow behind the head and slightly under the shoulders, which just aligns everything a little better for them, so that they got more chance of seeing those chords when they put the laryngoscope down and have a look. Assessing the airway is something that obviously the airway specialists will do, but one of the things that they might do is they might feel the patient's neck and look for the cricothyroid membrane. That really is if we get down to an area where we can't intubate, can't oxygenate, so CICO if you like, whereby the only option then is to put a hole in the patient's neck. Hopefully we're not going to go there, but sometimes you might see that happen. The other thing that the person looking after the airway will do is that they will stand at the head of the bed while you're getting all the stuff ready, and they will put a tight-fitting face mask, probably with the Mapleson C, or the water circuit as we sometimes call it, which is the collapsible bag that's filled with air and we can bag through that. They'll put a tight-fitting face mask to the patient's face and try and hold it there for a minimum of 3 minutes to try and get those SATs as high as they can. It's not just about the SATs though. What they're actually trying to do is wash all the nitrogen out of the body. You know, air is nearly 80% nitrogen. That's also in the patient's body. It's a gas that we don't use. So if we can wash that out and replace it with oxygen in the patient's lungs and in the circulation, then we've got longer to actually do the intubation when the oxygen's been taken away and you're having a look with your scope. Those SATs won't drop so quickly. So like I say, often the airway man will stand there with a tight fitting mask and just try and get those saturations up as high as they possibly can. Sometimes they might consider putting nasal oxygen on as well. There is a school of thought out there that says that if you put the nasal cannula in and once the patient's off to sleep, you can switch it up to 15 litres. The reason we don't when you're awake is because that would be quite painful. But when they're asleep, you can switch it up to 15 litres. And there is some evidence to say that that will stop the saturations dropping quite so quickly as well. So you may be asked to put some nasal cannula on as well. The One of the main things that you want is for the patient's blood pressure not to drop dramatically. So it may be that we attach an intravenous line to the patient and give them a good bolus of fluid if it's something that they can tolerate. Obviously, if they're a patient in severe heart failure, then that's something you've got to be a little bit cautious with. But you may need to give them a little bit of, for example, peripheral metraminol, just to try and get that blood pressure to come up a little bit before you start the process, because drugs like propofol will drop the patient's blood pressure and can make the situation a little bit difficult. If they've got an NG tube in, then we would aspirate that. It's nice to get as much stuff out of the stomach as possible. Some people will ask for cricoid pressure during the intubation, and basically you're looking for the cricoid cartilage, which is the first one down below the Adam's apple, and you're pressing on that to try and occlude the esophagus, which is behind the trachea, so that if the patient does vomit, it's not going to come up into the airway and down into the patient's lungs. So again, some people like that, some people don't, but if you can aspirate an NG tube, if you've got one in there, then you can be fairly convinced that there's minimal fluid in the patient's stomach. So that's what we're doing to start with, just to get the patient right. Now then, the equipment. So we need the monitoring attached, obviously, and the minimum is going to be your ECG. You need your oxygen saturations, which can sometimes be a bit of a challenge with the patient who's very shut down, but if we can get saturations, then that's obviously quite important. We will also want to know the patient's blood pressure. Again, it might be that the team who are looking after the airway may want an arterial line to be put in, so that we've got beat-to-beat measurements, easier to take gases, easier to take bloods, that kind of thing. But sometimes it may be that if we can get the cuff just to cycle very regularly, and we're reasonably happy that it's giving us reliable measurements, and it's not on the side that we're giving the drugs through. Just be aware of that, because I have been in situations where we've been giving drugs to send the patient to sleep, and in fact the cuff has gone up on that side, and therefore the drug is struggling to get to the heart. So just be aware that the cuff is on the opposite side to where you're actually giving the drugs. But one of the most important things, and I don't know if I've got one here. Have I got one here? I think so. No, I haven't. No, one of the most important things is your end tidal. I have got one here. Here it is in my little collection of goodies. So probably the most important piece of kit that you want is your lovely if I could just disconnect it, is your lovely end tidal CO2. And this is very, very important that we get this in place. So often it'll be put in the circuit as we start to send the patient off to sleep. When you see the CO2 returning, you know that you're actually managing to ventilate the patient, because you're getting the carbon dioxide gas out. But the key thing for this is that this is the gold standard as to whether you've actually intubated the patient's trachea or their esophagus. If you've intubated the esophagus, obviously you don't want to stay in there at all, because if you keep bagging that, you're just blowing at the stomach, and you're going to make that patient vomit fairly drastically sometimes. So one of the things that happens is that when we intubate patients and we've got the tube down there, everyone will turn around and look at that monitor and see if we've got some capnograph waveforms, because that confirms that we are actually in the trachea and not the esophagus. So that is really important that we have the end tidal CO2. So the equipment you're going to need to prepare. So let's start with the endotracheal tubes. So one of these boys, this one's a little bit curved, it's been in my bag curved up, but one of these endotracheal tubes, obviously really important. The size is important as well. The standard really outside of theatres is probably a 7 for a woman and an 8 for a man. Obviously, if it's a slightly bigger man, you might go to an 8.5 or a 9. But the other important thing is that if you do pick a size, it's important to have a size smaller available as well. You may not need to open it, but it's important that it's there and ready to be accessed, because if you struggle to get through the cords are a bit tight or the gap is a bit smaller than you imagined, you're then going to need a size smaller. So it's important that that is prepared as well. This tube should be well lubricated, especially around the tip and around the cuff, and the cuff should obviously be checked using a syringe on the pilot balloon just to make sure that it's intact, because sometimes they do get holes in them and it won't inflate, and then you've got to go through the whole process again. So one of these and a size smaller, grease it, check it inflates, make sure that this connector at the end is in and isn't going to come out, and you're ready to go with that. You will most likely need one of these. So you've got your laryngoscope. Obviously check that the light is working. It is on this one. There's different size blades. This one is a Mach 3, and I've got here as well a Mach 4. So I don't know if you can see, if I can get my hands out of the way, you can see that the Mach 4 blade is a little bit longer than the Mach 3. Okay, often these days people will use a Mach 4. It used to be when I started in ITU that they would use a Mach 3 more often, but the trend seems to be at the moment for a Mach 4. So obviously this is a detachable blade. These are all disposable these days, and just ascertain with the person doing the intubating what size blade they want. They may want a Mach 4 but a Mach 3 to be available, and vice versa, but you certainly need one that's working, so that needs to be checked and ready to one side as well. More likely these days, and I haven't got one because I don't possess one because they're very expensive, is you may see the video laryngoscopes often being used. It's the same principle, they're the same pieces of kit, it's just that you can attach a fibre optic cable to these ones, and it means that we get the image on a big screen. Slightly different intubation technique, not much, but a little bit different, but more interesting for the team because you can see what the person doing the intubating can do as well. And I think the time is coming, certainly if you're not stuck out on the wards, if you're anywhere else, ED or ITU, you're most likely to see people using video laryngoscopy rather than direct laryngoscopy, because it's been proven that the rate of success is much higher, the speed with which it's done is much quicker, and you know, there's less multiple attempts having to be done in order to get one of these tubes down. The other very important piece of kit is the bougie. Now, I'll be honest with you, I probably use one of these 80% of the time. This basically is if we're struggling to get round the corner, once you've got the tube in, to get round the corner to get to those cords, which can be a bit tricky with just the ET tube, the laryngoscope can be very, very useful as well. So obviously that goes through the cords. Then somebody, whilst the person controlling the airway looks after the bougie, mounts this over the bougie. The person then passes it through the cords, and whoever's helping then takes the bougie out and away. And it's important that you communicate that if you're in that situation, that once you've mounted the tube, you say to the person doing the intubating, okay, I have the bougie, because you're going to grab the end of the bougie then to make sure that it doesn't move. The person tubing is going to grab the tube and put it through the cords. They'll say they're through, and you will say, is it okay to remove the bougie? Bougie out, tell them that, and then inflate the cuff for them. So that's also very important. I would say that you certainly need to have a bougie to hand, and most of the time it's probably wise to have the bougie opened as well, because you don't want to be flapping about if it's becoming a bit difficult. Suction, very important. I was at a situation the other day where suction was absolutely essential. There was a lot of blood involved in this one, and the suction is key. But even if there isn't any blood involved, sometimes when the intubator first looks down, there's a lot of secretions down there, and you can't get a view because there's all this stuff down there. So the suction will be the first thing that they reach for to suction that out. And again, it's become a bit of tradition. I don't know if this is a worldwide worldwide tradition, but it becomes a bit of a tradition that the suction gets stuck under the pillow, often on the left-hand side, so the person doing the intubating, sorry, on the right-hand side, the person doing the intubating knows where it is. The laryngoscope is always going to be taken in the person's left hand, okay, so that's why the suction needs to be on the right-hand side, because they'll put that down, feel for the suction, and then they can suction with their other hand. It may be that there could be some problems, so you might need some other adjuncts as well. So the supraglottic airways, or the eye gels as they're commonly called, certainly in my part of the world, need to be available as well. So that's part of the checklist. Do we have access to an eye gel? Because if you're struggling to intubate, one of these things can rescue you. They're relatively easy to put in. They again need to be greased on the back, just helps it slide in a little bit smoother, so an eye gel needs to be available as well. You also may need the Goodell's ready, so the Goodell airway. Just sometimes when the patient's gone off to sleep, it can be hard, you know, if they've got a beard, for example, it's all a bit spitty. Sometimes it can be hard to maintain that airway and to ventilate them, and a Goodell can sometimes help that situation improve. The phoner set, so that's the front of neck access set. Now I'm glad to say now that we seem to be getting away from these standardized boxes produced by various companies of bits of equipment that I've never ever used and don't know how to use. We seem to be now going to the DAS guidelines, which is basically all you need is a blade, size 11 preferably, which are the nice pointy ones, a size 6 tube, and that bougie again, because in the front of neck access basically you're going to make a hole with the blade. You're then going to pull that blade across to make the hole bigger, put the bougie down, put the size 6 tube over it, hopefully get it into the airway, take the bougie away, and that's your airway sorted. I've never had to do it, I never want to do it, but that's the principle behind it, and it's nice and simple. You don't need a great deal of equipment. The drugs are obviously very important as well. So you're going to need to sedate the patient, you're going to need to paralyze the patient, and you may give them a drug like fentanyl or alfentanil, which can reduce the response the patient has to you sticking a laryngoscope in the back of their mouth, because that can cause hyper or hypotension, and you want to minimize that. So sometimes they'll ask for a little bit of fentanyl or alfentanil prior to starting with the other drugs. So the sedative agent commonly these days is propofol or ketamine. Propofol, as I say, tends to drop the blood pressure a little bit. Ketamine doesn't do that so much, but it has this dissociative element to it, whereby when people sometimes come out of ketamine, they can have some horrible hallucinations and things. But again, I think propofol and ketamine, it's kind of 50-50 these days. It always used to be propofol when I started. Now it seems to be a lot of people will prefer to use ketamine. You need the muscle relaxant, so you need to paralyze them. Most commonly these days, and this is in my practice, most commonly it's rocuronium. The rocuronium is going to be given almost straight away after the sedative agent. It needs about 40 seconds to a minute to work. So what you will see is that the propofol will be given, the rocuronium will be given, and then nothing happens for half a minute to a minute, and that's just to allow that muscle relaxant to work, and when the muscle relaxant works, that means that those vocal cords will actually open up. If you don't give a muscle relaxant, sometimes they're just shut tight and you can't get a tube between them, so that's why we give that. You may be asked to get ready something to sort out their blood pressure, so commonly these days that is metronidazole. Sometimes people use epinephrine, but more commonly it's metronidazole. It may be that, let's say, for example, the patient's already got a central line in, they might ask for things like noradrenaline. It's probably important to have some emergency drugs on standby, the ones that you use in a cardiac arrest, so an adrenaline, perhaps an atropine as well, just in case their heart rate does drop. And the other important thing is that once they're off to sleep, you need to keep them asleep. So just remember that you're going to have to get an infusion, a 50 ml syringe full of whichever drug you've decided to keep them asleep with. So again, propofol or ketamine, probably the most common ones. So if you have that ready, and you can even have it attached to one of their Venflons before you start, and then once the patient's actually intubated, you can just start that infusion straight away. If the patient's got a very low GCS to start with, then you're probably not going to need a great deal of the sedative, but you'll probably need something just to make sure that they're comfortable and flat and not going to start wriggling and cause you all kinds of problems once they've got the tube in. So that's the maintenance sedation. Then the other thing that should happen is about preparing the team. So this is about allocating the roles. So the person doing the intubation will often voice out loud what they're planning on doing. So I'm going to view with the laryngoscope, try and find the cords, try and intubate with a size 8, for example. I'll have one go. If I can't get it in, I'll start again. I'll reoxygenate them and have another look, might change their position slightly, might ask the person to take the cricoid pressure off if I've decided to use that, and then if I can't do it, then I'm going to defer to somebody else to try it for me as well. One of the key roles is to be aware of the time. So one of the roles of one of the people helping with the process should be to be aware of the passing of time, because there are some cases where people have probably been looking far too long without thinking to reoxygenate the patient. So it's important that somebody is aware of the time and just say, look, you perhaps need to reoxygenate again before you start again, or the saturations are starting to drop, for example. So you're going to need somebody who's going to be first intubator, second intubator. Do you want cricoid or not? Intubator's assistant is the person who basically is going to be passing the equipment to the person doing the intubating, and it's really helpful if when they've got the view that they don't then have to look up to find the equipment, because they want to keep their view, so they'll tend to put their hand up, and it's great if you can just put stuff into their hand for them. It's a bit like a surgeon. He doesn't want to look for the equipment because he's key focus is down there. He just wants things put in his hand at the right moment so that he can get on with his job once he's got a good view. MILS, so manual inline stabilization. So if the patient's got some reason to think that their neck might be a problem, you might need somebody who's actually just holding that head as still as possible throughout the process. And that's it pretty much, really. So it's a process that when you've been through many times like I have, everything starts to become second nature. But it's still important that you do run through that checklist. Be aware of the equipment that you need. So you need 2 trachea tubes, one big, one small. You need the laryngoscope. You need the bougie. You need the suction. And you need the other airways should they be necessary. Certainly you need to have the good old eye gel, not necessarily opened, but you can reach it, you can open it quickly if it's needed. You don't want it on the other side of the room or in another part of the department, so you need to make sure that that is available as well. And then once the patient is asleep and you've got them sedated, hopefully that's everything sorted. So that's it. That's preparing for intubation. I've got lots more stuff on this on some of the courses that I sell, so if you want to go and look at those on my website, which is criticalcarepractitioner.co.uk, by all means go and have a look. And then hopefully the next session I'm planning on doing fairly soon is going to be on cardiac output. So what forms the cardiac output, if you like, what are the key parts of it, and how does that inform our decisions when it comes to things like the cardiac output studies? What do those numbers mean, and what do we do about those numbers? What does it tell us, and what does it tell us to do? So I hope this has been useful. It's nice to be back again. As I say, it's been a long time since I've done this, and hopefully I will see you all very soon. Bye bye.